Thank you for your patience. I know I'm between you and lunch, but I'm just going to try to give you some food for thought. Of course, I have to say that thanks to this experience, hopefully the BTGs epitomizes the harmony that exists among all the hematologists. So what I'm going to speak today is not to convince you that steroids are the first line of choice for ITP. But what I'm going to try to tell you is that the newer understanding of the pathophysiology suggests a very systemic immune dysfunction, that part of which is antibody production against platelets, but the majority of the work is done by the T cells. So understanding this is very important in trying to put the treatment strategies into context, and particularly with the role of the newer agents such as the TPO mimetics, which will be covered by the next speaker. Of course, I'll be amiss if I didn't speak about the Harrington quote-unquote experiment in the 1950s, something that would never be approved by the ethics committee today. He dared to take the sera from the ITP patients, inject it himself. He recruited volunteers, including his own sons. And the result that you see is this 8 patients whose platelets dropped precipitously. And I trained in University of Miami, and I know that the stories go that he actually monitored his platelet count on a daily basis, and he survived. But nobody will want to perform such experiments. The usual approach is to do preclinical hypothesis generation, etc. What's important, what's happened in the last 50 years is the natural history of ITP that we understand is much better, clinically speaking. We do know that the ITP is not as much of a burdensome disease in terms of morbidity and mortality. Spontaneous remissions are uncommon in the adults as opposed to the kids. And if you're able to achieve platelet counts greater than 30,000 in majority of these patients from this meta-analysis, about 1,800 patients, then they do survive without any problems, except for those patients with severe ITP where there's a fatal hemorrhagic risk of anywhere between 1% and 5%, and this does increase with age. Now, going back to focus on the pathophysiology, this has been the known event that we have all talked about, the antiplatelet antibodies in ITP, which seems to be the villain of the piece, but I'll show you that our newer understanding that this is just made to be the villain, there is a mastermind behind this. The clinical relevance is that even though there are antibodies, we cannot detect them. It's not of clinical significance in terms of making a diagnosis. It's still a diagnosis of exclusion, and it's also called as isolated thrombocytopenia. I wanted to spend some time on the case scenario, but it's a typical imperfect case scenario of a 29-year-old male with previous history of diabetes who presents with petechiae and a platelet count of 20,000. Of course, I did put in the idea of doing a bone marrow, which may or may not be something. This is just to generate the thought process whether this particular patient needs a marrow or not. So how should this patient be treated? Keep these choices in mind: steroids, steroids and Rituxan, steroids and splenectomy, immunoglobulins, and ROGAM. So this context, I have to say that the definition of ITP has changed based on the Vincenzo consensus meeting published in Blood 2009. There is no acute ITP entity. It's called as newly diagnosed if the detection happens within the first 3 months. And it's persistent ITP, anywhere after that up to a year, and chronic ITP subsequently. And there's also definitions for severe and refractory ITP. Secondary ITP are events that are caused by other known conditions, including hepatitis C, HIV, lupus, etc. So we can talk the whole day about who should be treated, but the goals of treatment is very simple. In the newly diagnosed, which is what my topic is going to cover, you have to get the patient to safe platelet counts, stop the bleeding, and improve the quality of life. The threshold magic number is 30,000, and so any response above 30,000 is good, and CR is 100,000. Of course, this is this complex diagram of what the therapies might be available. I'll take you through this, and towards the end, you'll understand why drugs such as steroids and the other immunosuppressives and Rituxan play a large role, and also where the thrombopoietin receptor agonists may play a role, because all these are intimately linked and will give you the pieces of the puzzle. So what we know from this pathophysiology, as I had alluded earlier, is this antibody production. And the platelets that are coated by this anti-GP2B3A antibodies get beaten up in the spleen. That's just first part of the one part of the piece. But what we do know now is that the B and the T cells play a much larger role. If you look at that carefully and look at it as an evolving cytokine drama, and if you label it as ITP, rebel immunity, the villain is the B cell antibodies producing the platelet antibodies. The protagonist is, of course, the platelets, the innocent bystander, and who is also not affected physically, but the daily bread, in this case, the thrombopoietin is affected. The battleground is, of course, the spleen. If you think of this analogy, you'll be able to appreciate the pathophysiology. But the mastermind, as we know today, is not the B cells. The real mastermind is the helper T cell, which in turn is activated by the very robust antigen-presenting dendritic cell, which provides these peptides, and the helper T cells in turn stimulates the B cells to produce the antibodies. So even though the B cells are made to be the villain, the major dysfunction is the T cell. Furthermore, it's not just the helper T cell, it's the balance between the helper T cells and the regulatory T cells. The regulatory T cells are the internal police, which are supposed to control the helper T cells, which don't happen in this situation, and so you have an impaired T cell regulatory function. There are oligoclonal T cells, which allow the B cell production of antibodies. And this impairs not just the platelets, but also the megakaryocyte proliferation, maturation, and causes an apoptosis. However, we do know from a clinical experience that the T cell abnormalities can be reversed by treatment. The second piece of the puzzle is our understanding of how the platelet it depends so much on thrombopoietin. The first piece of the puzzle, it's very clear that immune thrombocytopenia is increased destruction of platelets. But what is more appreciated now with the research is that platelets are not produced as much as the demand requires. And this, in turn, is governed by the thrombopoietin. And the thrombopoietin allows the stimulation of megakaryocytes, proliferation, and pinching out of platelets through the JAK-STAT pathway, the same pathway that was discussed in the earlier session. And this may also have other implications on how these drugs work. And as you can see, in the clinical evaluation of thrombopoietin, if you juxtapose ITP against the normal patients, it appears that the ITP patients may have normal TPO levels. But if you compare where it should be and choose another bone marrow failure state such as aplastic anemia, the TPO levels are extremely high. On the other hand, if you look at it for ITP, it's lower. So it's inappropriately low. So the second piece of the puzzle that you need to understand is that the ITP is also a disease of decreased platelet production because of inappropriately low thrombopoietin. So these are the two pieces, and if you understand this, your treatment strategies become very easy. And so to answer my question that I asked earlier, are steroids the first line of treatment? I said I'm not going to convince you, but steroids are the first strike when diplomacy has failed. And so if you take the analogy of this drama further, this drama allows you to use steroids for restoring the immune function, because the steroids do go after the CD4, restore the balance, and the DCs do not recognize as GP2B3 antibodies, and possibly the ITP is cured. So steroids are like the UN, peacekeeping force, the blue berets, and it's best if they're quick and short. Obviously, they cause too much problems if they stay longer, and that's why you do a steroid taper. The UN withdraws pressure, the internal force, hopefully the internal police allows the T regulatory cells and asks the helper T cells to behave. However, if the steroids are much longer, there's collateral damage, there is diabetes, there's infection, and there's furthermore loss of the raw material supply, which is the thrombopoietin. So the rebuilding becomes a much bigger problem if this does not happen earlier, and particularly the replenishment of the thrombopoietin. Of course, there are other strategies based on the pathophysiology, such as using rituximab to deplete the B cells, splenectomy, and IVIG. We'll touch about each one of these points in a second. Obviously, steroids have a very quick mechanism of action. Within 7 to 10 days, you can get platelet count restoration. Only about 13 to 17% of the patients achieve long-term unmaintained remissions. Obviously, there are different ways of doing steroids. The two popular versions are using prednisone or dexamethasone. Prednisone is useful. It's short-lived, however, and many patients have to be given longer courses. And most of our patients hate this long-term steroids. Dexamethasone, on the other hand, the timing is very important. It probably is very useful when used very early. And I'll show you some studies to suggest that there may be a possibility of cure very early on, potentially in restoring this immune dysfunction. However, with both prednisone and dexamethasone, there are no predictive markers for responders. So we don't really know who responds and who will not respond. Now, there is this teasing study that was published from the South Korean group. This is an ASH abstract in 2010, where high-dose dexamethasone was compared to prednisolone. and the response was a wash. But the critique of the study was that the courses of prednisone and the high-dose dexamethasone given were not sufficient. On the other hand, there are single-arm studies which suggest that use of dexamethasone actually in the newly diagnosed setting allows the patients to recover the immune function very quickly. In this study, 84% of the patients responded, about 50% sustained response, and those patients who relapsed, all of them had the immune restoration at the second instance of the dexamethasone. So this raises the possibility of a cure if used early and short courses and quick courses of dexamethasone. This has been validated by other single institution studies. As you can see, the initial response is as high as 85 to 90%, including a 50% sustained response over 6 months. There are alternative first-line treatments, such as IV immunoglobulins, but they are temporary. They may work similar to steroids in efficacy only initially. However, the response is short-lived. For Rh-positive patients, obviously anti-D is an option to use. So moving on to what other strategies that can enhance the role of steroids and potentially getting to the point of cure. Now, rituximab has been used, the ubiquitous anti-B CD20 monoclonal antibody. Both low dose and quote-unquote standard dose of steroids are efficacious, as you can see from these studies. And one of the surprising, or rather a confirmatory evidence that Rituxan does play a big role in depleting what was the main will in the B cells. In this study published by Stasi, they actually looked at these oligoclonal T cells which turn polyclonal after successful rituximab treatment. What this data suggests is that the B cells, even though they're made to be the villain, they're controlled by the CD4 cells. But if you deplete the B cells sufficiently enough, you are able to disrupt the interaction between helper T cells and the B cells. And this is also confirmed by some long-term responses to rituximab. If you look at the 5-year data as presented in ASH in 2010, there are no cures with Rituxan. You can retreat them. However, the message is that those patients who achieve a CR remain in a CR. All the other patients don't have that benefit. And so this goes back to the previous slide that I showed. Perhaps B cell depletion is the only biomarker that we can use in allowing patients to receive rituximab right up front in the newly diagnosed setting. So what other strategy can we use? We can combine dexamethasone with rituximab as an initial treatment response. You can see that 2/3 of them responded, and with a sustainable 6-month complete remissions that were seen. And so it's potentially something that combines the immune restoration property of Rituxan and the disruption of the interaction between the helper T cells and the B cells. Obviously, you need larger confirmatory studies and randomized studies to answer this question. And finally, a few words about splenectomy. Since it is the battleground and it has been traditionally the way that many of the newly diagnosed patients who don't respond to initial courses of steroids are treated, there are early response rates, and many of the hematologists who have been treating for many years would swear that it's perhaps the treatment of choice, but there are complications. There are sepsis, thromboembolic complications, so it needs to be taken into consideration. You need to immunize the patient with pneumococcal, HIB, and meningococcal vaccine. You also need to remember, if you use Rituxan, the vaccinations may not work as well. You have to keep the splenectomy in perspective. So how should this patient be treated? This is a real life scenario of a young patient. And I did treat this patient with steroids and Rituxan, and he continues to be in a complete remission after 2 years now. Obviously, all the other choices fall somewhere in between and would very well work for the short period of time. So in summary, I want to tell you that the ITP is characterized by 2 pieces of a pathophysiological puzzle. The antibody production is just one part, but the main abnormality is a helper T cell dysfunction. There is increased platelet destruction because of this process. And the second piece is that there is also decreased platelet production because of TPO deficiency, relatively speaking. So the current therapies have to integrate both the immunosuppressives and also ways to keep the increasing platelet production. And that's how we come up with this whole algorithm of treating patients with ITP. And I want to stop here by saying steroids are the best first line, and I think future studies have to incorporate biomarkers because the risk-benefit ratio in ITP is very high, as opposed to many of the other autoimmune processes that we heard about in the last few days, whether it's a graft-versus-host disease or lupus and whatnot. So future strategies have to incorporate all the elements of care for the individualized patient. I think I'll stop here, and perhaps we'll allow the next speaker to come up and speak about the thrombopoietin agonists.